Good afternoon and welcome. This is Dr. Jill Einstein, the Director of Physician Engagement of the MAVEN Project, and welcome to today's session. This is January 25th, 2022, and I am very pleased to introduce our special guest speaker, Ariana Gordillo. She joined the National Association of Free and Charitable Clinics, called NAFC, in 2011, and is the Director of Strategic Initiatives. In this position, Ariana works daily with free and charitable clinics and pharmacies, as well as national partners. Her responsibilities include partner relations, volunteer activation and aid, member relations, grant program management, community outreach, and public speaking. She holds a Master of Arts degree in Latin American and Hemispheric Studies from the George Washington University and a Bachelor of Arts degree in International Studies from the American University in Washington, D.C. Ariana is a native of Lima, Peru, while currently residing in Arlington, Virginia, and volunteering at Arlington Free Clinic as an interpreter. And we're so pleased to have Ariana here today. One of our goals this year is increasing our volunteers' understanding of the clinics and providers that we serve. And Ariana has been a strong advocate for free and charitable clinics across the country and has been working closely with the MAVEN Project to increase the knowledge of the work we are doing to support community health centers. So welcome, Ariana.
Thank you so much. I really appreciate such a warm introduction. I'm excited to be here with you all, and I couldn't be more excited, honestly, about our national partnership with the MAVEN Project. So, as was mentioned, my name is Ariana. I am the Director of Strategic Initiatives for the National Association of Free and Charitable Clinics. And just to kind of boil it down as small as possible, basically what I'm in charge of at the NAFC is all of our relations with our national partnerships, as well as administering and managing all of our big grant and educational programs for the free and charitable clinics in the United States. And well, a little bit of everything. As many of you know, we are a nonprofit. And so with a nonprofit, everyone wears multiple hats. So you could find me on the phone with a very large, top whatever company. And then the next day sitting on the floor, stuffing envelopes for, acknowledgement letters or something like that. So we do a little bit of everything. Basically, I'm here to give a little bit of education on who we are and who our clinics and pharmacies are in the United States that we represent, our members. And so just to begin, I wanted to share with you, so who is the NAFC, the National Association of Free and Charitable Clinics? Basically, it's our mission to make sure that the underserved have access to affordable quality health care and to be really a voice in the United States promoting that quality health care for all and accessible health care. And so what the NAFC does is our biggest goal is making sure that everyone has access to affordable quality health care. And we do that not only by supporting people who need to get in touch with clinics, pharmacies, because they may have nowhere else to go, making sure that they don't end up in an emergency room. We also make sure and connect volunteers to organizations where they can lend their expertise, their time, whether that's one day a month or Monday through Friday. We also support our mission by making sure and supporting free and charitable clinics across the nation. And we do this in a number of ways. Some of the ways that we do this, and this is a very reduced slide on our screen today of the different things that we do, but I wanted to give a little bit of a picture of how we are able to have an impact on our clinics, on the people that we serve, the patients we serve across the United States. So some of the items that, or departments, I guess, that we do, the programs that we do include clinic support, which kind of is overall umbrella, which can provide, this encompasses connecting clinics to each other across the nation, making sure that I'm able to get organizations across the nation to have access to discounted or donated products and services, making sure that these organizations have access to incredible partners that can provide them with resources, not only for the clinics, but for the patients, volunteers, and staff, such as the MAVEN Project. as well as making sure that our members have access to medications through different national partnerships. One of the other things that the NAFC does in terms of what impact we can have toward our overall mission is making sure that we have funding programs. So I have a number of different national partnerships where a company might say, hey, I have this funding available. I want to make an impact with these clinics. I love what they're doing. And so we manage programs where clinics can receive funding for different programs, whether that be just the coordination of care or specific grant programs for telehealth or chronic disease management, COVID support. We've had a ton. So we have a lot of major partners that help us with funding for our clinics. Another one of the things that the NAFC is able to do is provide a lot of education and training. This is big for us. We do this in the form of, we do have an annual conference for free and charitable clinics, and we've had hundreds of them show up, executive directors to volunteer coordinators to medical directors, being able to provide them with sessions specifically for the needs of free and charitable clinics. Since COVID-19 started, we obviously have turned virtual in a lot of our education. So we'll have monthly webinars, educational training, a lot of Zoom. So I wanted to put that out there just as a shout out that we've been using that a lot lately in the past 2 years. A lot of training in terms of resources. If we have educational information, what we do as the kind of umbrella organization is to make sure and synthesize that and get our clinics the information they need. I know all of you probably get a million emails a day. So our job has been to kind of get what our clinics need, get what may impact them, their patients they serve in their communities, and send them the best information possible at the national level. Another one of the programs that we have, or ways in which we want to make sure we have an impact, is through disaster relief. Unfortunately, I would love for this not to be something we did, but unfortunately, there are disasters, whether that is weather-related disasters like hurricanes, fires, you name it. But there's also disasters like active shooters, or we had years ago, a clinic burnt down in Texas. Like, these are all disasters sometimes you don't necessarily think of. And so we partner with different organizations like Direct Relief, AmeriCare's Heart to Heart, Project Hope, in making sure that we can support these clinics with disaster relief, whether that is sending PPE masks that they can use when there's fires in California, or making sure that we're keeping track of every single clinic in the state, making sure everyone's safe, making sure that we reach out to all of our connections to get them the support that they need after, before, and during disasters. Another one of the programs that we have, which is a relatively new program I'm very excited about, is that we are now starting clinics too. We didn't have this expertise before, and now we have our own Volunteers in Medicine program within the NAFC, where we're helping people kind of being able to hold someone's hand through the process of, how do I start a free medical clinic? What do I do? Where do I go? So we have this too. Another one of the big parts of a program that the NAFC does is, we at the national level are in the world of public policy. So it is very important for us to make sure and be the voice representing free and charitable clinics at the federal level, whether that's with Congress, whether that's with different agencies like HRSA, HHS, etc., making sure that if there's something coming down the line or the pipeline that may affect our patients, our clinics, that we are there educating those representing us in the government to make sure that their needs are met, make sure that they have a voice. So that could be letter writing campaigns. Those are meetings with different senators and congressmen and agencies, just making sure that we're watching out for the work that is being done for the underserved. Another one of the big parts of what we've been doing in the past 2 years, as what all of us have been doing, is dealing with the COVID-19 pandemic. And so when that happened, we had to pivot, a word that I would hope I hope I don't have to hear it again, because there's been so much of it, but, making sure that when that struck, things had to go virtual. Okay, do we have resources for the clinics to be able to go virtual and do telehealth? Making sure that we had that relationship with MAVEN to be able to get that virtual assistance and consults. Making sure that, do we have a text messaging technology partner that can help to get the information to the patients, things like that. During COVID-19 also, we did, and we continue to do, is we've done a lot of product donation. Different organizations like Warby Parker, Vistaprint, even the White House reached out to us at some point and said, hey, I have these N95 masks, or I have isolation gowns, or different kinds of PPE. Can you manage sending that out to all of your clinics? So we did a lot of that, a lot of, you know, kind of managing different donations for clinics all across the United States. We also do work, we have an entire program in quality standards. And basically what this means is we have our own certification program for clinics based on, based on where we have a set of standards of best practices, policies, and procedures for these free and charitable clinics and charitable pharmacies nationwide. And so different clinics earn seals of excellence in terms of where they are in their development of what they are providing, whether it's, you know, patients, what they're providing in terms of coordination of care, protocols for labs, protocols for employees, volunteers, etc. And last but definitely not least, we do a lot of work in health equity. Now, I think there are two parts of health equity, I will say. There's the part of how our clinics are providing health equity and different programs that they have, and we're making sure to provide exposure and to provide a spotlight on the work that free and charitable clinics are doing in the realm of health equity. But then we've also taken upon ourselves to really create what we call a center of excellence at the NAFC. I am working with an organization called Just Health Collective, where we are doing a whole accreditation program on equity, diversity, and inclusion. We're providing training, education, self-assessments, leadership, anything and all you can think of. We're actually working on this and have an entire working group already set up for this. We're also making sure that we highlight the work that clinics are doing, leaders are doing across the nation in health equity. So we've partnered with the Robert Wood Johnson Foundation to put out an award for the last 6 years for health equity, kind of providing that spotlight on different leaders in our sector that have really made a change and a systems change in their communities, working with free and charitable clinics. So this is just kind of a reduced picture of the kind of work we do. Because we're a nonprofit, truly, we are very flexible in terms of if there's a new idea that comes to me, an organization that says, hey, can we try and do this with the clinics to help support the clinics, we can start a new program, you know, very easily. So we're always looking for new ways to, at the end of the day, make sure that everyone is able to access quality, affordable healthcare. So these are just some of the ways that we're able to do this as this organization. Now, some of you may be asking, what are free and charitable clinics? And I will say, and I have the definition for you and everything that you can read, but I will say free and charitable clinics, the basics of it, they're all 501c3 nonprofit organizations or programs of 501c3 nonprofit organizations who are providing some healthcare services to people who are either uninsured or underserved. And so I did want to touch upon kind of our free and charitable clinics. There are over 1,400 in the United States. And so, and if you count sites, which normally we don't, when I say 1,400 plus, that is in a way of saying headquarters of clinics. So if I'm counting sites, the number is probably closer to over 1,800 sites in the United States of free and charitable clinics, because some clinics have multiple sites. Now, just to give a high level overview of these clinics and pharmacies, there are different kinds of clinics. So there are free clinics which are completely free. There are what we call charitable clinics. All that means is that it may have some sort of nominal fee or sliding fee scale, but at the end of the day, they cannot turn anyone away for lack of ability to pay, and they do provide the service to the patient. There are free or charitable pharmacies. So pharmacies that provide their medications for free or for maybe some sort of suggested donation or something. There's also hybrid clinics now, as most of you would know, in past years, certain states have expanded Medicaid, for example. And so certain states like Virginia saw that there was a need for Medicaid providers, and maybe you don't live anywhere near within a 50 radius. let's be able to provide care for Medicaid patients, but also maintain our free clinic. So that's kind of what we call a hybrid clinic. About 80% of the clinics, at least from all of our data collection, are free clinics. But I wanted to make sure I kind of shared with you that there are all sorts of different types. Now there's also student-run free clinics that are at universities. There are, like I said, there's clinics that do mobile outreach mostly. There are all sorts of clinics. There's a clinic recently that are going a lot more into telehealth. So they might not be brick and mortar clinics, but there's a couple popping up that are doing a lot of telehealth. So there's a lot happening, but we are kind of the umbrella organization for all of them. Budgets are important. The reason I mention this is because free and charitable clinics are many times our counterparts that we are, of course, friends with and we work with, of course, are federally qualified health centers. The main difference between free and charitable clinics and federally qualified health centers, or FQHCs, are that our clinics receive little to no federal or state funding. So while there is a line item for FQHCs to receive funding from the government, our clinics do not receive that funding. There are a handful of states that have some sort of state funding for free and charitable clinics, but again, I think it's about 5 or 6 states max. And so, as you can imagine, how do these clinics sustain themselves? They sustain themselves just like we do. It's through individual donations, grants that they can get a hold of, community family foundations. So that's, and of course, their workforce, which I will get to in just a moment. About almost 50% of our clinics nationwide have budgets under $250,000. For those of us who know more or less how much of a budget a hospital or a private clinic needs to run, it's not a lot, but they do a lot of great work with smaller budgets. But we do have a good variety. I mean, there are 15% of, and this data is, the most recent data that we had is for 2020 that we collected in last year in 2021, and we're in the middle of collecting all of our data for 2021 now. So at least last year, the case was that 15% of clinics had budgets over $1 million, for example, but then you have 48% under 250,000. So there is a bit of variety there, and all of that depends on how they can fundraise, what kind of donors they have access to, and such. And I did want to share with you all that these 1,400 plus clinics nationwide, on average, do see about 2 million patients annually. And the number, it's been fluctuating a little bit because of COVID, obviously, but it's usually about 2 million patients annually. And in terms of visits, about 6 million patient visits annually. Now, I do think it's important, and it's helpful, especially for MAVEN, I think, and for volunteers at MAVEN, because you're providing a service that isn't always accessible to our clinics. I thought it would be really cool to kind of show you what services are provided at free and charitable clinics. Now, there are a ton of services, and more than I even have here, absolutely. Services provided at free and charitable clinics fully depend on whether the clinic can pay for a staff member to provide that service, pay for the equipment to provide that service, or what volunteers they can get to help them to provide a service. So, you know, I've visited a clinic who all they can provide is primary care, which is great. But then I visited, for example, Community Health in Chicago, who's next to 3 universities and has this wealth of volunteers. So they had like over 20, I believe, or 30 specialties just at their clinic because of where they were situated. So it really just depends on what the clinic can get their hands on, for lack of a better term. Just to give a quick little overview, about 84% of our clinics provide primary care, 75% provide labs, health education is a big one, so 75% also do health education. I do want to kind of get your attention to one of the numbers that I thought was very interesting, which is specialty care. Only 39% of our clinics reported being able to have specialty care at their clinics. So clearly being able to get consults, being able to provide specialty care in general, and being able to have access to that. I mean, there's a need. There's a need in all of these types of services, but I just wanted to draw your attention to that because I thought that was so interesting, especially for this call, where consults would be just so useful to our clinics who may not be at the epicenter or between, medical schools and big hospital systems and can't necessarily have volunteers right there down the street. So I also wanted to share with you, who works at these clinics. At free and charitable clinics, they use a volunteer staff model, meaning that there could be, I think it's less than 100 clinics are 100% volunteers, or there could be one paid staff member and then 20 volunteers, or 3 paid staff members and, whatever amount of volunteers. So it's a mix of both. And so there are a number of different types of volunteers and staff, whether it's medical, non-medical, dental, nurses, social workers, community health workers. There's all sorts of different types of volunteers and staff working at free and charitable clinics and pharmacy, just dedicating their time to their communities. There are over, at least in the past year, there were 200,000 volunteers at free and charitable clinics and about 14,600 paid staff, including part-time and full-time. And so I thought it would be really interesting for you to see these types of numbers to see how these clinics are supported. And so as you can see, volunteerism, very important for these clinics. And that's why it's so helpful to have volunteers that are able to, consistently come in, whether that's, again, like I said, it could be once a month, could be once a week, but that's so helpful for organizations that are trying to open up and expand as much as possible to their community. And the other aspect that I kind of wanted to just share with you all, because I think it is important. I think a lot of people, sometimes there's a lot of confusion, and I will say, to be completely transparent, before I worked for the NAFC, I really did not know much about free and charitable clinics. I didn't even know they existed at some point before working at the NAFC, and I've had to educate my family members and my friends who didn't know that free clinics existed or thought they were something else. I think knowing who our patients are is just so important and vital to being able to support free and charitable clinics and the work they do, and just to understand kind of who you're dealing with. Our patients are not, there are misconceptions about, I think out there, unfortunately, about people who are using the safety net are lazy or they don't work or things like that. And that couldn't be farther from the truth. Our patients, 60% of them, at least in 2020, were employed. An estimated 83% of them come from working households. So you may have a household where there is somebody who is employed trying to make sure and keep food on the table or get insurance. They're making these decisions every day. And so our clinics are there as almost a safety net below the safety net to try and help those who fall through the cracks, those who have 3 jobs and do not have time or the money to be able to see a doctor or take off of work and go to a doctor's appointment or anything like that. And so our patients not only come from working households, about 85% of them are uninsured, and we're seeing a lot of underserved and underinsured. So one of the examples that I like to give when kind of explaining that, and I don't know if it's the case still, but I know that years ago, I believe it was in Louisiana, I met a patient who said, well, here, we do receive a women's wellness visit once a year. And that's it. And so I'm considered insured, but that doesn't mean I'm getting my annual physical. That doesn't mean I have access to medication, scripts, anything like that. It's a women's visit, which is great, but that doesn't mean I am fully insured. And so that's where we're getting a lot of patients that, for example, you have a problem with Medicaid not offering dental. So where do they go for dental? They're technically insured. So, there's an increasing number of underserved individuals in the United States who may have insurance for the first time, who may go in and out of Medicaid, who, even if you have an insurance card, that doesn't mean that you can necessarily afford the copayment or the deductible. And so we do see that there are more and more underserved individuals. Our patients generally are kind of balanced out in terms of where they're residing. So this is not just free and charitable clinics don't just see patients in rural areas. They also see patients in urban areas and suburban. As you may be able to see from the screen, I just wanted to point out 36% of the patients are in urban areas, and equal 36% are in rural areas, and 28 in suburban. So there are people in need all over the United States, and it doesn't really, sadly, and not sadly, but it doesn't make a difference where they live. There is need everywhere, unfortunately. Now, our clinics, and this surprised me because I was always, and we were under the assumption, I think this has changed recently as a response to our communities, but it used to be that our clinics saw generally individuals between 18 and 64. Now, what we've recently seen, at least as early as or as late as 2020, is that there are more and more clinics seeing everyone, basically. So 40% of clinics specifically say that they see all ages. There's just one, we really, I think, have like 2 clinics that only do pediatrics. 5% see only up until 64. 18 to 64 is 23%, and some 31% of clinics just say 18 and over, and just a couple clinics only see people over 65. But what this tells me mathematically is that our clinics are seeing more and more patients of all age ranges. And I do believe, and it's always been our kind of motto, that our clinics are the community's response. So it's constantly reevaluating and assessing, what does your community need? Maybe your community no longer needs, this particular service, or needs more primary care, or whatever the case may be. One thing I've noticed, especially in the past 2 years, is that our clinics are truly adapting to their community's needs. And we find that that is just so important because these people are falling through the cracks. And so, and one of the other things I almost forgot to mention, in terms of who our patients are, our demographics for patients, and I do have a table for you there, but our demographics per patients are pretty much in line with what the demographics that federally qualified health centers see. But what I thought was a really interesting point once we looked at the data, the most recent data, was that compared with 40% of the US population, 64% of our patients were members of racial and ethnic minorities. I did find that very interesting. People that just had no access, whether it was no access to insurance or access to care. And so, our patients, I will tell you, if you ever get the chance to visit a free or charitable clinic, our patients are people who are working, who, may be working multiple jobs and are trying to make sure and make those awful decisions of putting food on the table or getting medical care. They're people who many times are, like I said, are working multiple jobs and just do not have access, or had some sort of chronic disease management, which, as we all know, and I know things are changing, hopefully, I'm excited, hopefully, for things to change for the better. But if you have something like a chronic disease like diabetes, insulin is not cheap. And so how do you expect to be able to afford that if, you're having other issues such as transportation, barriers to care, literacy and such. And so our clinics are really there to take care of to take care of those who are most in need, to make sure that they're also, reducing ER utilization so that patients don't end up in the hospital for something like a mismanaged chronic disease. And so our clinics are really, really there, taking more time and really looking at the whole whole person in terms of their health. I just as a quick anecdote, I interpret for my local free clinic, the Arlington Free Clinic. And I will say that when I'm interpreting, it's funny because when I go to a private practice, my own doctors, sometimes, you know, it might be a 10-minute, 15-minute appointment. But at the free clinic, I've been interpreting, and sometimes they run between 45 minutes and an hour where they're asking them everything. So if they have let's say it's a hypertensive patient or a diabetic patient, they start talking about nutrition. They start talking about, okay, well, who do you live with at home? Who does the grocery shopping? They really, at our clinics, kind of get into it and really look at the social determinants of health that are affecting the patients, because many times there's a lot of different aspects that are causing a patient to not be compliant with their medication, or maybe the patient got a script, but they can't afford that medicine. And so, okay, let's figure out a way to get you on a patient assistance program or to get you a donated medicine through our in-house pharmacy. So that's one thing that I just wanted to share with you all that I really do love about these clinics, is that they take the time to really get to know the patients and really be a medical home for them. So with that, I just wanted to give you guys a bit of a high level overview of who we are and who our clinics are and what they do. We do have an entire website where you can see exactly different infographics, and you can even find clinics near you if you're interested at all. But you know, we're always happy to help, and we couldn't be more excited to bring yet another incredible resource to the providers at these clinics. And with that, you know, I'm more than happy to take if there are any questions from our group.
Ariana, thank you so much for that great overview. And I really appreciate that. I'll have you stop the share, and we do have some questions in the chat that I'll share with you. And volunteers, if you have any questions, you can feel free to add them to the chat, and we'll try to get to as many as we can. Could you please address the dynamic of why some free clinics are not able to accept any patients with Medicaid?
Right, sure. So in order to accept patients with Medicaid, you either have to have a Medicaid waiver in order to have a Medicaid provider be considered a Medicaid provider as your entity and also the provider. So you have to make sure and do that. But also, if you want to accept and bill Medicaid, there's a whole process in terms of becoming a Medicaid provider in that sense, which is it's a very long process to be able to become one. Some clinics run into issues with if they have, for example, with the IRS, their mission is that they are a free clinic that accepts no insurance, then they can't go against that, or they would have to change their information with the IRS, of course. So except it's not that they can't accept Medicaid, it's that if they do, it's a model change, and many of them now do. But it's just one that is a decision at the board and clinic level, if that is something that they want to start taking.
Thank you. With all of these free and charitable clinics, why doesn't MAVEN have a relationship with more clinics? Great question, Dr. Zemmel. We are looking to partner with many free and charitable clinics, and to be able to help to support their primary care providers. Ariana, can you speak at all to that?
So that's kind of why I'm here and why I'm so excited about this. We just started recently, and we were in talks in 2021. And so our partnership is relatively new. And so we are on it. We've been having talks about this, and MAVEN is now actually on our website and everything listed as a partner. So it's actually something that we're developing now. So not to throw my contacts at MAVEN on the screen or anything, but we're going to be talking about making sure and doing a lot more educational webinars for our clinics, because a lot of clinics don't know that MAVEN exists. And so that's what we're going to be working on during 2022 in the first quarter. I believe Timmy and I are trying to see about doing a webinar in February for clinics and making sure that they have the information about this new partnership, because just like you all, we still have a lot of clinics out there and people out there who have no idea who we are or what our clinics are. A lot of our clinics don't know who MAVEN is. So that's exactly what we're working on now. And that's why, we thought that it would be a great idea. And well, we didn't think, we were offered the opportunity to be able to speak with you all and kind of share who we are, to kind of start that back and forth, learning of who about this partnership and such. So we're on it. That's my answer.
That's great, Ariana. We're really looking forward to continuing that. Next question, is there a reason some of these clinics are not looking to get FQHC status and funding? What would be required of them to get that designation?
Real simple. Becoming an FQHC is a huge process. I have not gone through all of the ins and outs and details of it. I just know that it takes, we've had some of our clinics become FQHCs. It takes years to be able to go through all of the process. You also have to be a very economically strong clinic in order to become an FQHC, because there's a lot of regulations, for lack of a better term, red tape and such that you have to go through. And so it is a very lengthy process, and you need a huge staff on it. If I'm being completely honest, anecdotally, that it takes a lot of work to become an FQHC. Also, I think a lot of the issue that some clinics have in going toward that route is that as an FQHC, yes, you are supposed to see everybody, but that amount of the uninsured that you can see is a way smaller percentage. And what these clinics have seen is, and they work with their FQHCs, please don't get me wrong, there's great relationships there. While let's say an FQHC, and I'm not saying this is the average, but may see 80% insured individuals, 20% uninsured, what these clinics are doing is saying, okay, but there's a lot more uninsured people that still don't have access. So they've been focusing on those. So I think some clinics want to keep seeing patients who have no insurance at all. So it's a matter of the process is very lengthy and costly for a clinic to undergo. And it's also clinics wanting to focus on those who fall even further through the cracks.
Thank you. There is an Indian community center, that's Southeast Asian Indian, in Milpitas, California, that runs a free clinic, but it could benefit with your collaboration, as this provides services to visitors who are not residents here and then get sick. The clinic has been closed in the past 2 years due to COVID and lack of staff, and there are physicians that volunteer, and they also get some help from college students. So I'm going to connect you with our volunteer, Dr. Sula, after.
That makes me so happy. I love that. I haven't heard of that organization. I would love to get in contact with them and see how we can help them too, for sure. Thank you.
It's in their community center.
Okay, in Milpitas, right?
Yes, I think
FCC based in Milpitas, but they're hoping to start giving services. So right now the clinic has been closed.
We can definitely help with that. We've had clinics in COVID, and I didn't go too much into COVID because I know that we're all slightly over COVID. But no, during COVID, we had clinics that had to completely change the way they did their jobs. We had some clinics that had to close for a second, to reorganize, to figure out where do we get the PPE that we need? How do we provide the services with people who can't come in? Or how do we provide services if our providers, we have a lot of providers that are in populations of risk. So yeah, so we had a lot of clinics go through that, and we've been helping a lot of them. A lot of them are back. Yeah, I would say most of them are all back, but yeah, we can definitely help with that and see how we can support them. Thank you. I really do appreciate that.
Thanks, Dr.
I'll try to contact you sometime in the future.
Okay, yeah, I'll make sure, well, I have it on my last slide, but I'll make sure that you have my email.
Okay, great. Thank you so much. These series of questions are all connected, and you have touched on them already, but I'm just going to read through them.
Yeah, of course.
What percentage of patients seen in safety net clinics are undocumented? What percentage of patients are seen that are just visitors or in the US temporarily, such as people that are here on work visas?
Those are actually numbers that are, I believe, in our data survey this year that we have added. There are many clinics who see the undocumented. And some clinics don't. It depends on where they are, to be honest with you. There's some clinics that have tight restrictions on that, and very few of them, to be honest with you, depending on where they're located and such. And if they have strict restriction in terms of, we are seeing, if they, for example, put in their mission, we see American citizens that are uninsured, I can't imagine a clinic has that, but there are some that ask for information about that, but I would say majority don't, because at the end of the day, it's a population health issue, and we don't want any people to go without care. And if I'm just speaking on behalf of the NAFC, but documentation, immigration, that's our job, is to provide care. Our job is not to be the police. So I would say that the majority do see the undocumented. I don't have exact percentages right now, because I do know that that's something we're looking at now, and which is a little difficult, because there are some clinics who on purpose say, we don't care whether you have your papers or not, we just want to care for you. And so they may not collect that information about how many are undocumented or are documented. So that's something that we are trying to figure out, because I do think that there's a story to tell there, and I do think that's important. But yeah, we're in the middle of looking at that right now. But yeah, we have, I would say most clinics, a lot of clinics see the undocumented. And if you look at clinics in different cities and regions, especially urban areas, border towns and such, they see a ton of people who, dreamers and such, who may not have papers, but are needing help. And yeah, so we have a lot of people who need help out there. And yes, clinics see the undocumented for the most part. I do encourage about a specific clinic, if they're looking for care and such, to connect with the clinic directly to make sure that they don't have any other, eligibility requirements. Most, I would say, just because we're on that topic, if there are any eligibility requirements, it'll be like, if they have any, it'll be something along the lines of, please attest to the fact that you are under 200 or 300% federal poverty level. That's generally what eligibility is at free and charitable clinics, but it just depends on each one. Each one of these clinics, and I apologize, I didn't mention that earlier. We support them, but they are not our clinics, if that makes sense. So they all have their individual boards, their individual medical directors, all of that. They're their own organizations. We just support them with best practices, and everything we talked about earlier. But so it really just depends on the clinic. But I would say most of them, if they have any sort of restriction, it's just on income, in terms of we're only taking patients that make up to 300% FPL.
Thank you.
But information is coming. Yes, we are looking into that actually right now. We should be getting all the data back by the end of February.
Great. Voluntary public service organizations, from food pantries to volunteer fire and ambulance companies to religious charities, struggle to attract and keep volunteers, and usually rely on a dwindling core of stalwarts and a fluctuating number of more transient participants. Does this problem seem to obtain as much with free and charitable clinics, and how does this affect continuity of care?
Yeah, volunteer activation and recruitment is always one of the top 5 or 10 needs of free and charitable clinics. And that goes, I hate to say it, but that goes for any nonprofit that uses volunteers. That's why, yeah, it is a problem. And that's why I won't shy away from sharing with you all that during COVID, there were a lot of volunteers that left because of the pandemic. And that's where you have to, I think, as an organization, start thinking, okay, how do we support our sustainability? How do we support that continuity of care? At free and charitable clinics, I will say, while volunteer recruitment is a high need, how do I say it? I do find that clinics find new and different ways to get more volunteers. There is a sense, I anecdotally at least, I have gotten a sense that there is a bit of consistency. They'll have volunteers who, some clinics have very drawn out even programs like the Arlington Free Clinic, where I volunteer, where you tell them exactly how much can you volunteer, when can you volunteer, and they have it really like into a process so that they can know what to count on, right? So I think once you administer that more into a black and white program of, these are what my needs are, this is what you can give me, this is when you can give me your time and all of that, they do much better actually in terms of their sustainability for what they need. But no, it is, unfortunately, it's a problem for us too, for sure, getting volunteers that you need. especially around COVID, that was a big issue. I think normally clinics do an okay job and have a consistent amount of volunteers that they need, but in the past 2 years, it went down, especially with volunteers that were older and at risk. So that is one thing that I've told our clinics, hey, if you have a lot of, please, try to strategically see if you have older volunteers that may be at risk for things like variants and such, don't just rely on older volunteers who may be at risk for these things. Make sure that you have a diversity of volunteers. Make sure that, are you using student volunteers from your local university too? Are you pivoting and using telehealth for your older volunteers because they still want to help and they may just have to do it remotely in a case like a pandemic? God forbid that ever happens again or continues much longer. But, yeah, volunteerism, it's an issue. I think it's an issue for any nonprofit, but I will say that as somebody who volunteers and has toured so many clinics, our volunteers, once you step into a free or charitable clinic and connect with a patient and see, have a conversation with a patient or other volunteer staff, you're committed. I've never seen, I think that the hearts of volunteers that provide their time to free and charitable clinics, they're incredible people. So I will say that they give a lot. So while it is difficult, and I wouldn't lie to you, it's difficult for all of us. I think they do a pretty good job at making sure that to incentivize the volunteers, making sure that they have, get to know them and things like that, and really give them a wonderful experience as well. So I think they do a pretty good job, but yes, it's hit all of us.
Great, thank you. I know we still have a bunch of questions, so we'll try and get through as many as we can. What is the relationship between MAVEN and NAFC? And you've touched base on this a little bit, but you could just briefly say again.
Yeah, sure. So MAVEN has been actually generous enough because MAVEN really wanted to make sure that our clinics had access to as a resource to clinics who really needed this. And so MAVEN has actually, if we're being completely frank, MAVEN has discounted their services and everything for NAFC clinics to be able to have even more access to all of the incredible resources that MAVEN has at their disposal, from obviously the consults and the volunteer workforce to all of the educational resources that MAVEN has, dashboard and all of that available to our clinics. So MAVEN has actually offered to do that. And we're actually also working on different possible programs together. So MAVEN and I have been talking about possible collaborations with other organizations to be able to provide this kind of resource to even more clinics. And yeah, so the partnership is both educational, discounted access, and making sure that we're both kind of sharing resources and education with each other as well.
Great, thank you. How long have the free clinics been in existence?
Ooh, great question. So I believe the earliest clinic that I know is, I think it's Social Welfare Board in Missouri, and I want to say it's 1907 maybe. A lot of them came into existence, I believe, in the 40s, and there was a big boom of new clinics in the 80s and 90s. Yeah. So as early as the 1900s, from what I've looked at.
That's amazing. Thank you.
Yeah.
What about universal electronic medical record in the cloud for patients on the move, like farm workers?
Healthcare on the cloud. Do you mean electronic healthcare records or being able to access telehealth?
Susan, do you want to unmute yourself just to ask?
Both are really big problems. For example, I could see a farm worker who has a skin cancer, and before it can be treated, they're on to somewhere else. I could have taken a biopsy, but they don't have any way to access the biopsy. Meanwhile, they've ditched that one phone. They have a different phone number. They don't have a consistent email address. So I need to have a little card for them to be able to get their record so they can show it to others, as well as clinic communicate to clinic. And if you have Epic, you can often see some of the records. Like I could see records from FQHCs here in San Diego or around the country. But if you don't have that system, you're out of luck. So do you have is there something within the organizations that you're helping them organize their electronic medical records, and also to make them be able to talk to each other and for the patient to retrieve important information?
Great question. I actually have a couple of answers to that. So one, the NAFC, well, that's my job. I work very hard at convincing big companies and organizations the value in supporting our clinics and supporting our patients. And so one of the things that I have done is negotiated for a number of them, but I will start with two good examples of both Practice Fusion and Athena Health to provide our clinics with completely donated EHR systems. And so we have hundreds of our clinics are on those same systems because I'm able to negotiate with them and tell them, okay, this is what kind of impact you're going to have in the community if you can provide, with access to your EHR system. I have never been lucky with Epic to do that, but if you know someone, please let me know. Epic is one of those that I would love to have a conversation with. I just have not been lucky in that area yet. I also do have different negotiations with smaller EHR companies who have decided to discount their services greatly to NAFC free and charitable clinics in terms of having access. Now, I will say, being able to provide portal access for patients in EHRs is now something that clinics have to do. And so that is why I've had conversations both with the two biggest EHR companies that our clinics use, which would be Practice Fusion and Athena Health. And they've both made sure that our clinics have access to be able to provide that patient connection to their records immediately. I really loved your example about the biopsy and everything about farm workers. That is an issue, absolutely. And our clinics tell me all the time, there are patients who have different phones that, are seasonal patients. And so we have clinics who have, one of the things I will tell you about clinics, and I know I'm kind of repeating myself, but they really are the community's response, meaning that they constantly assess, okay, this is not just a private practice patient. If my patients are farm workers, then I know that I have to have different tactics in order to make sure that I am reaching them. So Community Care Clinic in Boone, North Carolina goes out and has an entire outreach program where they go out to a specific community of farm workers at their homes and goes directly to them. Night Ministry knows that in Chicago a lot of their patients are the homeless population. And so they do mobile outreach directly and go to them. And they try and stay as much in contact as possible. Now, you have to understand that when you have patients who may be transient, who may not have a consistent cell phone number, you're going to have to keep kind of going at it. You're going to have to keep asking for the number and making sure that you can connect with them in any way possible. But I think it's, and just to add to that too, in terms of technology, that's kind of where we come in, where I've been negotiating more and more with different technology companies to be able to do things more on the cloud. So I just got I have a relatively new partnership with Echo, where they have these really, really cool state-of-the-art stethoscopes where it records what you're hearing, and it's really crazy cool. But it goes straight to a platform so that a doctor can do outreach on a street to a patient, but it goes straight into the cloud so that they can then kind of meet the patients where they're at. So I'm constantly trying to have conversations with different technology companies to be able to make that connection technologically. I think I had a conversation with a company they had software to be able, like you said, the dermatological software to be able to take pictures in a different way so that they can do it with maybe a doctor in California when they're in Missouri. So I will say that's always in process. We're trying to get access for our clinics to that kind of technology. That kind of technology is still developing, as we all know, and it's expensive. So that's kind of where we come in and working hard to see how we can get help for that. But at the end of the day, the clinics have to know their communities. They have to know their patients. And so a lot of them change their tactics in order to really meet their patients where they're at.
Great, thank you. MAVEN is a particularly good resource to serve subspecialty needs in rural areas, regardless of one's insurance status, when a given subspecialty may not be present. Is MAVEN doing all it might in this regard? And Dr. Cole, I know that this has definitely been an important topic for you, and I know with our strategic partnerships that they're working on defining their strategy on that. And I know I'm going to set you up with talking with Timmy Shrump, who's our director in that area. Ariana, could you comment at all, and you may have already done this before, but just like the approximate percentage of clinics that are in rural areas that are part of NAFC?
Yes, there's actually 36% of our clinics are in rural areas.
Mm-hmm.
So yeah, there are clinics in areas especially that may not have, for example, we do a lot of advocacy work in broadband access. There are clinics in areas where they don't have maybe access to broadband or internet access. And so, yeah, there's a lot of our clinics in rural areas trying to make sure that their patients can get that healthcare, or in food deserts, for example, where they don't have access to nutritious food or anything like that. So yeah, about 36% of our clinics are in rural areas.
Great. Do you have a list of the clinics by city and state? And are there free and charitable clinics that are not in your network, and why?
Sure. And we do. The clinics is actually a list of the clinics. We don't share that publicly just because, as you can imagine, there are spammers out there and we don't need them harassing our clinics. But we do have two things. We do have a find a clinic feature on our website where you can literally put in zip code or city and state, whatever you want, and find all the nearest clinics to you. But also we will be sharing our list of clinics with MAVEN too, so that they know exactly where they're located. And not only will we share a list of our active member clinic list, but we'll share our all identified free and charitable clinics. Yeah, there are clinics that are not active with us. A lot of times it's that there are some that don't know that we exist, if I'm being completely honest. And that's why we're constantly outreaching to different free and charitable clinics who may just not know that we're there, and we don't know if they're there. So I know that one of the physicians earlier told me about a clinic in Milpitas, California that I didn't know was there. And trust me, I would have known that if I had heard that. So I'm very excited, and there's only so much you can do, and they're popping up all the time. Unfortunately, I wish there wasn't a need. So what we do to look for them is, whether it's Google searches, conversations with different state organizations that may know about them, the Department of Health and such. We try to identify as many as possible, but many of them might just not know us, to be honest with you, in terms of being active with the NAFC. So I will say, every day we have new clinics join the organization and get the resources that they need. So that number is constantly growing. Yeah, I would say that that's the biggest reason. Many times they just don't know about us.
We're at the top of the hour. Ariana, thank you so much for taking the time to prepare and present to our physician volunteers. This was so helpful in giving us greater understanding of the clinics that we serve. And we're so appreciative of our partnership with NAFC, and we look forward to continuing that and obviously impacting the clinics and providers that we're all trying to support. To our physician volunteers, thank you to so many of you who joined today. We had a great turnout. Your questions were spot on as usual, and I just appreciate our volunteers, interest and dedication and passion to volunteering with us and, offering their time and expertise. And so this was wonderful. I hope everybody has a great day, and thank you so much.